blessed person. The next speaker is, as the corona came and the more and more digitalization was there, we have seen a lot of medical persons using computer, and there were a lot of software were there who were making the diagnosis, just like this dermatology software. We don't need, I think in future we will not be needing dermatologists to make the diagnosis. Just a picture can make your diagnosis. So there are a lot of improvement, a lot of new things in this field as the artificial intelligence is improving. I will give you one example. In 6 hours, artificial intelligence just figure out 6,000 chemicals that can kill you. 6,000 chemical warheads in just 6 hours. What will this artificial intelligence, machine learning will do, the nanotechnology will do? So the next topic is being presented by the Professor Muhammad Tariq. He is MRCP, FRCP, he is Professor of Internal Medicine at AQU. He is Associate Dean Education and Chair Department of Education Development Program. He is also a Director Postgraduate Program at AQU. Please, ladies and gentlemen, for next talk, please welcome Professor Muhammad Tariq. Please, sir.
Bismillahirrahmanirrahim. Assalamu alaikum, and thank you for inviting me for this talk. Is it working? Okay. So today I was given this title, or maybe of my talk, Innovation in Medicine, Current and Future Medicine. So I was thinking, what should I talk about here? So what in my mind, clinical care and clinical teaching, learning and assessment and training of the residents and medical students goes hands in hand. So whenever you talk about clinical care in an academic medical center, I think the training aspect of the care, I think, need also to be discussed. So my talk would be focusing on the innovations in clinical care as well as teaching and learning. So I have no financial interest, arrangements or affiliation that would constitute a conflict of interest. I think this is a mandatory slide when you are working at AKU. So I will include always. So some background about the history of medicine. It shows that how approach has changed from illness and disease from ancient times to the present day. A number of new technologies, number of new things, like as just said, that artificial intelligence is there, nanotechnology is there, precision medicine is there. Number of things are there, and again, assessment modalities of students and residents, online assessment, online teaching, online learning. I think number of things are coming up. So present medicine is changed. The Hippocratic Oath was written in ancient Greece in the 5th century, which is direct aspiration. Still we use that. Innovation of microscope was consequence of improved understanding during the Renaissance. And prior to 19th century, humorism was considered as, and which is replaced by germ theory later in 19th century. And military doctors started to do some surgeries in trauma, and then the concept of surgery begins. Public health measures were developed in 19th century, which rapidly grew. Advanced research centers opened in 20th century, and then connected major hospitals. Mid-20th century, antibiotics were introduced. So that was a new era which came. And these advancements, along with development in the chemistry, genetics, radiography, led to modern medicine. And medicine was heavily professionalized in the 20th century. So this is some background where how it started, maybe very early in the Egypt, in India, and in China, I think medicine started. And then Muslim civilization, Muslim doctors, a number of, they worked on a number of things, and then slowly and gradually, UK and US and other areas in the Europe, and they took all those, and then structured medical practice started. So you see here, this is William Osler. You see, he is inspecting, he is palpating, he is auscultating. And here what he is doing, he is contemplating. He is just standing there and thinking about the diagnosis, about now what I feel that so many or a number of technology would come. Yes, definitely would come. Artificial intelligence would come. But still human mind would remain a major thing in the diagnosis and management of the thing, because the artificial intelligence again would be guided by the human mind. So whenever you have a complex patient, what I do usually when I'm seeing a complex patient sitting in the special care or high dependency unit and having difficulty in diagnosing, then stand there and think about thinking process, contemplation. So that's what William Osler was doing about maybe 100 years back. And then you get some good ideas from students or maybe a resident, and then you come up with the diagnosis. So history taking, physical examination, patient communication, clinical reasoning skills, approach towards the patient, professionalism, all learned in clinical setting. And clinical teachers in an academic medical center, a clinical teacher and a clinician. So there is a difference between a clinician. I strongly believe that a clinician is a person who diagnoses a patient, and a clinical teacher who holds a degree, or maybe who hold an academic title like assistant professor, associate professor, or a professor. That person has the responsibility of diagnosing a patient as well as diagnosing the ability of the learner. So हमारी responsibility is सिर्फ patient care तो है, लेकिन हमारे साथ जो students and residents हैं, I think we need to train them as well. So now about some new innovations which we are more interested in today. So artificial intelligence. What is artificial intelligence? Artificial intelligence is basically a computer or machine learning. The machine is fed with a huge amount of data. You can see a data is fed. A machine is fed with a huge amount of data, and then machine diagnose a patient, maybe develop a treatment plan through an algorithm or a number of things. So that's a machine learning which is now coming up and up again. But in some of the specialties, particularly in cancer management and in cardiovascular, early detection of some of the cardiovascular diseases, it has been used. In some drug discovery, it has been used. But I think a lot need to be done because a significant cost may also be involved in incorporating this artificial intelligence into the clinical practice. So you see, artificial intelligence is a branch of computer science capable of analyzing a complex medical data. But still, I think you need to feed in that data where human person would be needed. So I think without human, you may not be able. Their potential to exploit meaningful relationship with data can be used in the diagnosis, treatment, and outcomes. Machine learning can be create algorithms by using large amount of patient data and information. As I already said, algorithm can be used to get earlier and better diagnosis and to tailor treatment and management plans. And current examples include faster and more accurate review of mammograms, early detection of heart disease, and drug discovery mechanism, and a number of papers published. Number of people are doing in the West the artificial intelligence but I think still a lot need to be done. This is just in its infancy, artificial intelligence. But I think it is a potential for the future. And for that, we need to look up for new clinical trials, maybe new research, that how artificial intelligence can be. And then we need also see how cost effective it would be. So that's again a very important question I think we need to look into. And you can see here again in cardiovascular disease, it has been used, and then artificial and cancer research and precision medicine and drug toxicity and safety. In these circumstances, it has been used with potential benefits. But I think again a number of new research modalities are need to incorporated into practice. What is precision medicine? Precision medicine is an individualized or a personalized care. This is also coming up very much into the cancer research, but in other research, again, it is being used. Precision medicine is a personalized, individualized care, keeping in view the genomes and genetics of an individual. So, an emerging approach for disease treatment and prevention that takes into account individual variability in genes, environment, and lifestyle for each person. So, the treatment modality or the diagnostic approach could be personalized for individual patient. One patient with a similar cancer, another patient with a similar cancer, or maybe any other disease, where if you are using precision medicine, the treatment may be individualized. So that again would need a genomics and gene identification. Again, a significant cost may be included into it, but I still, maybe in future, it may be a good potential. Treatment can be personalized based on one's background rather than using universal plans. And again, in oncology research, it has been used. So you see here, this is a traditional medicine. The group of people are treated with a medication therapy, adverse events for all, no benefits for all, maybe benefit for all. So this is a traditional way of managing. Stratified, maybe if you see a person is from any specific background and look at those things, and then maybe a stratified treatment, then you can have some group benefits on those. Precision medicine, you look at the individual patient level, genomics, lifestyle, history, health history, medical records, and a number of other things. So, and then you identify and do a treatment plan for that individualized patient. Not easy. It's very difficult, but I think it's coming up in future. So just I wanted to highlight precision medicine here. Again, review of precision medicine, cancer patients, number of literature is coming up, and in complex medical conditions, again, precision medicine is coming up. So individualized care, precision medicine for complex patients. Currently, only cancer patients are using in some instances, but but again, the future, we may see more and more of precision medicine. We may not see, but it would depend on all the clinical trials and research which would come up in future. Telemedicine, I think telemedicine with COVID-19, it is becoming more and more popular. And we have been using, I've been doing clinic online, and we have been seeing patients from maybe from Dubai and from outside as well. Referred patients are seen online using Zoom link, using sometimes those video WhatsApp. Which is very, very commonly used, and I think most of you may be doing this telemedicine, and definitely the patient touch is not there, but a number of times you may do, if you have seen a patient, complex patient from maybe outside interior of Sindh or maybe Punjab, and you have seen that patient, and now a follow-up if you want, they can be in their hometown and they can have a follow-up with investigation and things, so that you can have so in follow-up visits, I think this is very, very important, but maybe in initial visit as well. But maybe once in lifetime, you would, maybe once at least in that illness, you may need the physical touch as well. So in some of the cases, without physical touch, you can manage as well. So again, telemedicine, tele-ICU is becoming more and more common. I've seen a number of critical care specialists in Pakistan managing ICU in US. 2 or 3 of our critical care faculty from Aga Khan University, they are now, they've resigned from AKU, and they're only doing tele ICU management of US patients, and they've been paid. So from here, the residents and people and a junior consultant sees the patient in those ICUs, and these are the people who are sitting on the Zoom link or maybe a video WhatsApp, and then manage patient from here. So again, tele ICU and tele medicine is becoming more and more popular, particularly with the advent of this COVID. I think it has increased significantly. Again, I think there are literature there. I'm not going into details. Virtual reality. Virtual reality is coming up very much into it. I think virtual reality is you feel yourself immersed into by using those kind of devices. You immerse yourself into the real situation. And then a number of new things are happening. Healthcare simulation environment in which learners can experience visual stimuli delivered via computer graphics and other sensory immersive capacity of virtual reality, meaning that simulated environment surrounds the learner's perceptual field. The learner feels that he's himself indulged or immersed into that virtual reality and then feel accordingly. So, yeah. So it has been used for psychological conditions by providing an augmented reality environment. Pain management sometimes can be used. And then virtual reality is significantly used for training of residents and medical students. For medical professionals where they can face and practice challenging scenarios before they have to face them in front of the actual patient. So again, virtual reality is coming up again and again. And here are some of the literatures about virtual reality. Electronic health records. Electronic medical records, another thing which is coming up. In the US and maybe in the UK and all the civilized countries or advanced countries, it is there. But in our country, some of the institutions are doing partial electronic medical record. Few of them are doing health records to some extent, but I think this is the future. You would feed all the data into the system and take history examination and everything on the electronic health record system. Then you have a supporting formulary there for medication, maybe a medication alert. If you put any medication for the treatment, you would be alerted with the interaction or other things. And then supportive literature may also be there. Guidelines may also be provided in the electronic health record. So it's a comprehensive package which a number of institutions are doing in the US. AKU is working on it. Hopefully by next year we'll have full 100% electronic health records in our system. So let's hope everything goes well. Yeah. So I just highlighted some of the new technologies which are coming up. I'm sure there are a number of nanotechnologies, a number of other things are also there in the literature, but I think there is some limit to it, so I just focused on those. Clinical learning innovation during COVID-19. Now what COVID-19 led to? Social distancing, closure of medical schools, less number of team members in the individual team, use of PPEs, decrease in number of non-COVID patients, seeing patients with mostly non-touch technique, bedside teaching and team discussion limited, exposure with quarantine and isolation, less time spent at the bedside during the rounds. So I think we all experienced, particularly when COVID was very much into our system, I think we all experienced all these. But I think this led to development of a number of teaching and learning modalities for our students and residents, and I think some of them can be continued for future as well. So medical schools suspended, literature on that, virtual bedside teaching rounds. So students connected to a video conference room remotely and were able to see and hear the attending physician-patient encounter. The students were sitting, in some of the institutions, students sit in the conference room with social distancing in a screen, and those are connected to a computer at the bedside, and the faculty with one or two residents sees the patient, and then a discussion, and the students can be connected and can be involved in discussion at the same time. So this has been used. Live stream ward round, a tool for clinical teaching during ward round. Now what in this Australia they did, live stream ward round, a consultant and a registrar or a resident does a round, and a single medical student via mobile phone was connected and listen everything what they do, see and listen everything. And then what students does, student case preparation phase. Student takes notes during the rounds, ward rounds, remotely. Student formulates ward round presentation if they will be able to, a junior resident like, and then on the third day, everybody sits into a conference room, and then student present those cases. So this was the live stream ward round which happened, and I think this can be easily used maybe in post-COVID as well. Virtual care, new models for caring, again virtual ward rounds have been happening right, left and center in number of institutions. We also did that. You can see here this is a Zoom meeting going on where this EEG was projected, and the students, they are all connected here, residents and students, and this is the faculty. So, and then a discussion takes place. So that's how the virtual ward rounds and virtual learning takes place for the students. Again, mixed reality handsets in hospitals helps protect HoloLens with dynamic 365 assets using Microsoft Teams to send a secure live video from. Now, if I'm seeing a patient in a COVID area using this HoloLens, and then from the HoloLens a video develops, and that is projected into the conference room, and the patient and the students and residents sitting in the conference room sees what exactly is going on with the patient. They can see the patient, they can question directly. So these are the new modalities. The mixed reality handsets again come up here, and maybe in future again with infection control in a high dependency unit. We may not take all students into the high dependency units. So then these are the modalities which can be used. Mixed reality teaching rounds where they saw the patient from the clinician's point of view with electronic records superimposed on the Microsoft HoloLens. Students were able to interact with the clinicians remotely, which facilitated participation and clinical reasoning. So I think that's how. So students' involvement through virtual grand round could provide an opportunity to reach clerkship learning objectives, minimizing the risk of exposure and nosocomial transmission and reducing the demand for personal protective measures. Again, smartphones can also be used. Virtual, I already discussed that. Simulators and virtual learning also supports education during the COVID-19. Now, just a few slides about assessment. This is one of the consortium of International Consortium of Assessment, Umbrella Consortium Assessment Network, UCAN. It's a German consortium and world's largest assessment consortium, which is currently present. And AKU has become part of this consortium recently. And 77 UCAN partners of different institutions, and they have more than 7 lakh stored items and maybe a number of exams they conducted through the online system. So you can see the different modalities. This is just one consortium, but there are a number of new modalities of assessments of trainees, residents, interns, which is coming up there. Item management system of the UCAN system, where you can develop questions, store questions, and in a secure environment through a typical attributes into the online system. And then these questions can be grouped together, and then you can choose questions from there to conduct exams online. Exams could be online, exams could be tablet-based, exam could be paper-based. So T-exam is a tablet-based exam which can takes place. Again, tablet-based exams are coming up. A number of students are still we are doing it, but this is through this system. Whenever you are into the system, you are having exam of your students. There is a security system where you cannot browse internet. So the exam you can conduct. Okay. Campus, again, computer-based exam, tablet OSCE, tablet presenter, Edgar. These are different modalities which are coming up in this assessment systems, and I think I'm not going to detail of those. Just wanted to show tablet-based oral examination. Examinator is a quality assurance mechanism of assessment system where you identify what is the difficulty index, what is the discriminant index. So a number of things are coming up, and this is the future actually of assessing of students and residents. And these are different modalities which can be used. So in conclusion, innovation and medicine goes together, and in my mind, I think clinical care and clinical training of residents and students again go hand in hand. The next few years, medical technology innovations will fundamentally transform healthcare in the system. The innovation technologies are promising for diagnosis and treatment as well as for learning. And there is a need for future research and clinical trials which are appropriately designed before these emergent technologies, innovations find vast application in real clinical setting. And COVID-19 pandemic necessitated remodeling of medical education. Virtual rounds again and live stream ward rounds have been introduced. And innovative solutions to virtual teaching can facilitate valuable and safe educational experiences. So I think I'm going to stop here, and I think I took 2 or 3 more minutes, but I hope if you have any questions, maybe later on we'll have